This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. Okay, this is going to be Chapter 10, Drugs Used to Treat Cardiovascular Emergencies, Part 1. And introduction. Often the initial presentation of the cardiovascular disease occurs as an emergency in the out-of-hospital setting. EMS providers play an integral role in the treatment of cardiovascular emergencies. Drug therapy for cardiovascular emergencies is the most extensive of any disease state in which EMS personnel provide drug treatment. This chapter focuses on drugs used in out-of-hospital cardiovascular emergencies. This is a list of antiarrhythmics, and before we get too far into this, right after I give you a list of them, what I'm going to do is I'm going to kind of explain the major drug categories, and then we'll refer back to that with each one of the drugs. So all of these we're going to go over in this section. These are antidysrhythmics, or I am going to stop the arrhythmia that you're currently in. And what this is this is Von Williams, and Von Williams scale, or Von Williams classifications. This is where a class 1 would work, right here, and a class 1 is a sodium channel blocker. And this is a class 4. Class 4, I'll just use the calcium up here as a calcium channel blocker. A class 3 is a potassium channel blocker by nature. And then a class 2 is actually a beta blocker. Now again, the betas are sympathetic nervous system receptor sites. We have 4 receptor sites: alpha 1, alpha 2, beta 1, beta 2, and the betas are muscle. So what this is going to do is this is going to decrease chronotropic and inotropic rates of the heart, which means harder, faster, stronger. We're going to reduce that. So each one of these are the phases of the cardiac cycle overall in this. And in these phases, sodium initiates in via fast channels, and it allows us to generate an action potential that will attain threshold. After it initiates the action potential into a depolarization wave, then calcium rushes into this section and makes our heartbeat harder and stronger. In this, potassium rushes out, and this is into phase 3, beginning of phase 4. And when potassium rushes out, we have a little bit of control on that if we block it, or block the potassium channels. Again, calcium rushes back in before phase 4, and this repolarizes all over again to start in phase 0. Adenosine, and this is how adenosine works. Adenosine's a little different. We give adenosine, and I'll give you the simple version of it really quick. It pretty much stops the electrical activity of the heart, and how adenosine works is we're pretty sure that it works off of L-type calcium channels and decrease the amount of calcium entry into the cell. Thereby, without calcium, pacemaker cells have a decreased chronotropy and dromotropy here, which means they do not function. So for a period of the half-life of it, which is about 30 seconds, up to 30 seconds, we can get a systole whenever we give them adenosine. Alright, so first, and this is by alphabetical order, first drug here, this is a primary care drug, and I won't repeat this every time, but in this section here, this means that you need to know everything about this drug. So generic on adenosine is going to be adenosine. The trade name is going to be Adenocard. Mechanism of action, naturally occurring nucleoside that's present in all body cells. Adenosine slows conduction time through the AV node and can interrupt the reentry pathways through the AV and SA nodes, and can restore normal sinus rhythm in patients with paroxysmal supraventricular tachycardia, including PSVT associated with Wolff-Parkinson's-White syndrome. So, tell you what that means here really quick. We have a heart and a reentry pathway defect, sinoatrial atrioventricular node, and essentially through whatever mechanism it is reoccurring or re-entering into the AV node. So what essentially adenosine does, the Barney answer, is going to be it cuts out the conduction system for a second and lets the heart reset. Now we see this on the monitor in the form of this, which is a nice flat line of a systole. Now what that gives us is it gives us time so that the heart will reset itself to the sinoatrial and the atrioventricular nodes. That's the theory on this anyway, or the primary pacemaker sites of the heart. Now adult dose in this is going to be 6, 12, and 12, given rapid. The reason it's given rapid is the half-life on is 30 seconds. Very simply, if you do not give it very rapidly, you should give the medication with a fluid bolus directly behind it. Pediatric dosings are going to be 0.1, 0.2, and you can give another additional 0.2 milligrams per kilogram. Again, rapid IV push, and that's because of the half-life. Contraindications on this are going to be hypersensitivity to adenosine, any kind of high-degree heart block, second or third-degree AV block, or any kind of sick sinus syndrome where we don't think the sinus node will actually fire off again. Pharmacokinetics onset in 20 to 30 seconds. Duration is less than 30 seconds, and this is eliminated simply by cellular metabolism. Amiodarone. Amiodarone is our primary antidysrhythmic. The generic on this is a primary care drug as well. The generic on this is amiodarone, and the trade name is Cordarone. Mechanism of action. Acts directly on all cardiac tissues, thought to prolong the duration of the action potential and refractory period without affecting the resting membrane potential. Relaxes vascular smooth muscle, decreases peripheral vascular resistance, and increases coronary blood flow. Also blocks sympathetic stimulation. Now, we have multiple areas. Whenever this has a Von Williams classification, let's start this off like this, of a potassium channel blocker, or a class 3. Now, that's not all it does. It's a multi-use antidysrhythmic. So it does do that. It also blocks the calcium channels, which makes it like really a class 4. And it increases parasympathetic tone, which makes it like a little bit like a class 2. So, very simply, amiodarone hits multiple receptor sites simultaneously. The calcium channel blocking property of this can actually affect the overall blood pressure by dilating out the vascular beds. Adult dose on this is 150 to 300 milligrams IV over 10 minutes, followed by 1 milligram a minute over the next 6 hours. Now, how we normally do this is the initiating bolus is 300 milligrams, and about 5 minutes after that, 10 minutes after that, you can give another 150 milligrams. For PVCs or VTAC with a pulse, we would give 150 milligrams over 10 minutes. Pediatric dose on this is 5 milligrams per kilogram, IV bolus, with a max of 15. Contraindication. Now, this thing blocks an awful lot of things, so most of your contraindications should make sense. If you have sinus node dysfunction, any kind of high-degree heart block, cardiogenic shock, because I'm going to depress the cardiac function, pregnancy, lactation, amiodarone should not be administered to patients with bradycardia because of the increased incidence of syncope, and very simply, it's going to retard or slow down your heart a little more. Pharmacokinetics, rapid onset IV. Duration is 26 to 107 days. That means that we are not going to get back. We can never pull back with this drug. And what I mean by that is please ease your patient into a therapeutic index instead of bam, and now I have to deal with an untoward effect. So ease them into it very simply, and their patients will do a lot better. Atenolol. This is general knowledge. I'm going over this one here really quick. General knowledge means that all I want you to understand is, instead of the adult dose, pediatric dose, contraindications, please look them over. You may receive a few test questions over them. However, the mechanism of action is what I want you to know. And atenolol is a beta-adrenergic blocking agent. So cardioselective for beta-1 at low doses with little or no effect on the beta-2 receptors. Now at higher doses, we see them also affecting the beta-2 receptors. Now what that means is beta-1 and beta-2. Beta-2 is bronchial dilation. Beta-1 is harder, faster, stronger of the heart. So why we give it is to slow down, decrease the heart rate, decrease blood pressure, as the indication of this, management of hypertension, angina pectoris. The angina, by reducing the amount of contractile force strength, we reduce myocardial oxygen consumption. Again, contraindications on this. If their heart rate's already slow, why would you want to slow it down even more? Any high degree heart blocks or any kind of pump failure or pulmonary edema. Atropine, primary care. And this is a parasympatholytic. Generic for atropine is atropine, and the trade name also is atropine. How a parasympatholytic works is you have the sympathetic and the parasympathetic nervous system, and these things are continuously maintaining, going up and down, increasing tone and decreasing tone to maintain homeostasis, and this is kind of like a teeter-totter. So whenever we look at a parasympatholytic, we generally want the effects of the sympathetic nervous system. So what a parasympatholytic would do, or an anticholinergic, would be to block the parasympathetic nervous system, thereby leaving a sympathetic nervous system dominance. Mechanism of action. Atropine blocks the action of acetylcholine on receptors on the AV and SA nodes in the heart. Stimulation of the parasympathetic nerve fibers is blocked, resulting in enhancement of sinus node automaticity, atrioventricular conduction, an increased heart rate, and an increased cardiac output. Very simply, I give them atropine. The indications for this is for bradycardia. Adult dose 0.5 to 1 milligram to a maximum of 0.04 milligrams per kilogram. AHA currently has capped that at 3 milligrams. Via ET, some experts suggest to administer 2 to 2.5 times the dose if we have to go down the tube. Please dilute in 5 to 10 mils of sterile water for injection. Normal saline for injection may facilitate absorption, or sterile water for injection may facilitate absorption better than normal saline, but may produce more negative effects on the arterial oxygen pressure. So most people have on hand normal saline. The book suggests that it increases its availability a little bit better if we do it with sterile water. Pediatric dosing on this is 0.02 milligrams per kilogram IVIO every 5 minutes, 2 to 3 doses. Single dose no less than 0.1, no more than 0.5 milligrams in children, and 1 milligram in adolescents. Contraindication, hypersensitivity to atropine, acute MI, type 2 or second or third degree heart blocks. So again, high degree heart blocks on this. If we find somebody bradycardic and we want to increase their heart rate, that is a very high degree heart block or a complete heart block that we're talking about here. So very simply, we should probably be considering transcutaneous pacing. Pharmacokinetics is immediate onset, duration of 4 hours, and eliminated in the urine. Cardizem, primary care drug. This is a calcium channel blocker, and it is similar to Verapamil. What the calcium channels do is not only do they initiate, but they're also in the middle of that cardiac cycle that we saw. So right around between 2 and 3, 1, 0, 4, 4, we got an influx of calcium. So this would block the influx of calcium, decreasing contractile force strength and causing relaxation of smooth muscles. Slow calcium channel is similar to mechanism of action. Slows calcium channel blocker similar to Verapamil, inhibits calcium influx through slow channels into the cell of the myocardial and arterial smooth muscle. Intercellular calcium remains at subthreshold levels insufficient to stimulate cellular excitation and contraction. Dilates the coronary arteries and arterioles and inhibits coronary artery spasm, thus increasing myocardial oxygen delivery. Slows sinoatrial and atrioventricular conduction, decreasing total peripheral vascular resistance, and reduces arterial blood pressure at rest. May decrease the heart rate. Adult dose is going to be 0.25 milligrams per kilogram IVIO bolus and administered over 2 minutes. You could actually add a couple of more minutes to this as well. We can get untoward effects if you push this too quickly. May be repeated in 15 minutes if needed at a dose of 0.35 milligrams per kilogram. Pediatric dose is not recommended. Very simply, most clinicians cap this dose, this initial dose here, to 20 milligrams total. So please remember that number. That's like the magical number for Cardizem. You'll see most of the ERs doing that as well. Contraindications, if they have any hypersensitivity, if they're already hypotensive, high degree heart block, sick sinus syndrome, unless they have an artificial pacemaker in place. Myocardial infarction, pulmonary edema, Wolff-Parkinson's-White syndrome with rapid atrial fibrillation or flutter. Wide complex QRS tachycardias of uncertain origin are also a contraindication for this. Pharmacokinetics, onset in 3 minutes with a duration of 1 to 3 hours, excreted in the urine. Corvert, general knowledge. Generic on this is Ibutilide, or trade name is going to be Corvert. Short-acting class 3 antidysrhythmic agent, prolongs the cardiac action potential and increases both atrial and ventricular refractoriness. It's recommended for acute pharmacological conversion of atrial flutter or atrial fibrillation. You may see them actually use this in the emergency room or as an adjunct to electrical cardioversions in patients whom electrocardioversion alone has been ineffective. Its short duration of action makes it less effective than other antidysrhythmic agents for maintaining sinus rhythm once restored. Adult dose, adults greater than 60 kilograms, 1 milligram IV infusion over 10 minutes. If the arrhythmia is not terminated, a second dose may be given 10 minutes after the end of the first infusion. Pediatric dose is not recommended on this. Contraindications is hypersensitivity. This is a long time to wait. Onset is going to be 30 minutes and duration of this drug is going to be 24 hours, excreted in the urine and feces. This is probably not an ideal EMS drug. Digoxin. Digoxin does two things for us. It kind of blocks the sodium channels, thereby reducing conduction velocity, and it increases calcium ion. Now, what that does is that increases inotropy or contractile force strength. Now, digoxin's perfect patient that it's given for is somebody that has atrial fibrillation with rapid ventricular response. Now, let me kind of explain that. So, in AFib, the atrial fibrillating, and the F waves are essentially hitting the AV node. So the AV node on AFib people is actually controlling the rate. It's kind of like the gatekeeper. So what we do is by giving them digoxin is slow conduction velocity through the AV node, and for the actual ventricular muscle itself, we make more calcium ion available, so contractile force is increased. Inotrope. Now, what that does for us, whenever a person loses their atria, they lose 30% of their cardiac output right off the bat. So, by increasing contractile force strength of the lower ventricles, what I can do is I can increase some of that cardiac output back. Very simply by increasing the contractile force strength. And by slowing it down, I get greater filling into the ventricles so that the cardiac output is greater still. It is ideal for that type of patient. Now, here's the bad things about digoxin. Most therapeutic indexes are like this. Well, we bring our patient into them and they kind of idle through this. Digoxin's therapeutic index is like this. Now, if we remember about a therapeutic index, this is the minimal amount and it doesn't do anything, and this kills 50% of the lab rats. So it is very difficult to get our digoxin patients therapeutic because they need to be in this very fine window for therapeutic index on digoxin. It is not one of those drugs to where you can miss a dosing in the morning and say, well, I'll just double up tonight. That cannot occur. Will do very bad things. It will give us all kinds of untoward effects. So digoxin, again, general knowledge, we don't push this in EMS, but a lot of your patients will be on it. Mechanism of action, generic on this is digoxin, and the trade name is Lanoxin. Mechanism of action, digoxin is a rapid-acting cardiac glycoside used in the treatment of congestive heart failure and rapid atrial dysrhythmias. It acts by increasing the force and velocity of myocardial systolic contraction through its effects on the sodium-potassium ATP pump. By significantly increasing stroke volume, it increases cardiac output, positive inotropic effect. It also decreases conduction velocity through the AV node. Very, very, very fine dose here. Most people, when they take a pill, are on 0.25 milligrams daily. So we can't take 2 of those. If we take 2 of those, all of the untoward effects or the side effects are going to be seen in this. Pediatric dose not recommended for out of hospital. Contraindications: do not administer digoxin to patients who are hypersensitive to digitalis preparations, with uncontrolled ventricular dysrhythmias, or with atrioventricular heart block. Pharmacokinetics: onset 5 to 15 minutes, and duration is 3 to 4 days, eliminated in the urine and feces. Esmolol, again, another general knowledge drug. Generic is Esmolol, trade name is Brevibloc. Esmolol is an ultra-short-acting adrenergic blocking agent with cardioselective properties, but devoid of intrinsic sympathetic activity or membrane-stabilizing quinidine-like activity. Its hemodynamic effects are mild, with potency as a beta blocker of 1/100th of that of propanolol. So Esmolol, very simply, is a beta blocker. We use it for the treatment of sinus tachycardia and supraventricular arrhythmias in the field. Sometimes, but for the most part, in our region, we do not use Esmolol as a primary care drug. Labetalol, general knowledge. This as well is a beta blocker, decreases contractile force strength and rate. Do not administer labetalol to patients with hypersensitivity to labetalol, bronchial asthma, congestive heart failure, pulmonary edema, cardiogenic shock, bradycardia, heart block. Do not administer betalol during pregnancy because it can result in apnea, low Apgar scores, bradycardia, or hypoglycemia in newborns. Labetalol is the primary name, or the generic, and Trandate is the trade. Very simply, labetalol, it's a law, is a beta blocker as well. Lidocaine, primary care. You're going to see a lot of people still using this. Efficacy suggests that amiodarone is probably a better antidysrhythmic. The generic on this is lidocaine. The trade name is xylocaine. Mechanism of action: exerts antidysrhythmic action, class 1B. Now, class 1 in Von Williams is a sodium channel blocker. It would work on the fast channels by suppressing automaticity in the His-Purkinje system and by elevating electrical stimulation threshold for the ventricle during diastole. It is used to raise the threshold for ventricular dysrhythmias and to lower the threshold for defibrillation and cardioversion. So it essentially assists in popping them out into a perfusing rhythm. Progressive depression of the CNS occurs with increasing blood concentration, produces anticonvulsive and sedative actions, and we're going to see another medication when we look at the neurological section. The Dilantin has the same Von Williams classification as lidocaine, and that's because Dilantin is also a sodium channel blocker. Adult dose in this, 1 to 1.5 milligrams per kilogram IV push. Repeat in 3 to 5 minutes as needed, up to 3 milligrams per kilogram. Following conversion, you need to begin a maintenance infusion at 2 to 4 milligrams per minute. IMSA, the only way that you would give it an IMSA is if they had an allergy to amiodarone. Pediatric dose, 1 milligram per kilogram also, 3 milligrams per kilogram max. In IMSA, you can utilize this if it's refractory to amiodarone. Contraindications, hypersensitivity to lidocaine. Prophylactic use in AMIs, we don't do that at all anymore. Ventricular ectopy secondary to untreated bradycardia or AV block. Adams-Stokes. Wolff-Parkinson's-White syndrome. Pharmacokinetics on this is onset in 45 to 90 seconds with a duration of 10 to 20 minutes. This is excreted in the urine. This is a general knowledge drug. Low-pressor also is a beta blocker. Five milligrams per kilogram, and you can give 3 doses of this, up to 15 in case they're using it in the emergency room. This would decrease myocardial oxygen consumption and contraction of the myocardium. Phenytoin. This also has a this is Dilantin. This also has a neurological use. We will not use either of the Dilantin as an antidysrhythmic, nor do we generally use Dilantin in the field for seizures, but this is an anti-seizure medication. Generic on this is phenytoin. Trade name is Dilantin. Mechanism of action: phenytoin acts on sodium channels within the neuronal cell membrane by limiting the spread of the seizure activity and reducing seizure propagation. By promoting sodium efflux from neurons, phenytoin tends to stabilize the threshold against hyperexcitability caused by excessive stimulation or environmental changes, capable of reducing membrane sodium gradient. It also has a class 1B antidysrhythmic property similar to those of lidocaine and tocamide. Also class 1B agents. Adult dose on this is 50 to 100 milligrams by slow IV bolus every 10 to 15 minutes until the arrhythmia has been abolished. Total dose can reach 15 milligrams per kilogram. Toxicity has occurred. Administer no faster than 50 milligrams per minute. So this is a nice, even flowing drip. Pediatric doses are not recommended. Don't administer phenytoin to anybody with a hypersensitivity to phenytoin or propylene glycol, intolerance of alcohol, presence in the IV formulation, bradycardia, sinoatrial or atrioventricular block, or Adams-Stokes. Pharmacokinetics: onset in 30 minutes, duration 10 to 15 hours, and it is excreted in the urine. Now, very simply here, takes quite a while for it to onset, and it sticks around like luggage. Let's be aware of that. Procainamide. This is actually a drug that's on the comeback. Procainamide is the generic on this, and Pronestal is the trade name. Class 1A, which also makes this a sodium channel blocker. Antidysrhythmic. Pretty much decreases myocardial contraction through the AV node, reduces conduction velocity in the atria, ventricles, His-Purkinje system, increases the duration of the refractory period, especially in the atria, can produce peripheral vasodilation and hypotension, especially with IV use. Adult dose on this is 20 milligrams per minute by IV infusion until one of 4 things occurs, and these 4 things need to be remembered. The arrhythmia has been suppressed, hypotension develops, QRS segment widens by 50%, or a total of 17 milligrams per kilogram have been administered. A maintenance drip after this needs to be initiated as well at 1 to 4 milligrams per minute. Contraindications: procainamide should not be used in patients presenting with pre-existing QT prolongation and torsades de pointes, hypersensitivity to procainamide or AV block. Pharmacokinetics: onset in about 5 to 10 minutes and a duration of 2.5 hours. And it is excreted in the urine. Propanolol, general knowledge. I'll make this nice, short, and simple and sweet here, so let's just don't drag on forever. Propanolol is a beta blocker. Now, the big thing with propranolol is if you have anybody that has asthma or COPD, it is absolutely contraindicated. And occasionally we'll see people prescribing, or that have been prescribed propranolol, and they have those diseases. It makes it more difficult if they're in acute exacerbation of their asthma for us to open them up and dilate them out. Verapamil, primary care drug. This is a calcium channel blocker. This is going to decrease contractile force strength and essentially add hypotension to your patient. Indications for this, SVT, PSVT, it is very potent on the vessels. Dilates the coronary arteries quite well, but it can actually make our patients hypotensive. Inhibits calcium ion influx through slow channels into the cells of the myocardium and arterial smooth muscle. Dilates the coronary arteries. Decreases SA-AV node conduction. Decreases the total peripheral vascular resistance, which means turns vessels that are all squeezed down into, dilates them out. Adult dose in this, very slowly, 2.5 to 5 milligrams IV given over 2 minutes. 3 minutes in the geriatric patient. If necessary, a repeated dose of 5 to 10 milligrams IV can be administered every 15 to 30 minutes, given over 2-minute periods. Maximum total dose of verapamil should not exceed 20 milligrams. The pediatric dose is not recommended in the out-of-hospital setting. Do not administer verapamil to patients with a hypersensitivity to the drug, severe sinus bradycardia, because it could make them bradycardic to begin with, severe CHF, or high-degree heart blocks. It's also contraindicated in patients with Wolff-Parkinson's-White syndrome, atrial fibrillation, or flutter, because verapamil may accelerate the heart's ventricular rate. Pharmacokinetics, onset 1 to 5 minutes, duration of 10 to 20 minutes, and excreted in the urine and feces. Antihypertensives or antianginal agents. Vasodilation is our primary thing that we're probably going to be doing in most of these patients. Antihypertensive and antianginal, by decreasing the workload on the actual heart, what we generally get is a decrease in chest pain that's actually occurring, because most of it's, the chest pain that we see is about a supply and demand issue. So most of our things, and this is nitric oxide, is going to do this right here for us. So one of the ways that this is nitroglycerin that we're kind of showing here, how it actually works. The development of nitric oxide, which causes direct vasodilation. So let's start talking about this. So this whole section is all going to mess either with the blood vessels, their ability to constrict and or dilate out, or by dilating them out, we will create more blood flow. Apresilene, general knowledge. This is an arterial dilator. Directly affects the vascular smooth muscle of arterial resistant vessels, resulting in vasodilation. Its hypotensive effects may be limited by sympathetic reflexes, which increase the heart rate, stroke volume, and cardiac output. The postural hypotensive effect is reportedly less than produced by sodium nitroprusside. So very simply on this, general knowledge, I just need you to know the mechanism of action. This is the ACE inhibitor algorithm here, or how this actually works. So let's talk through this here for a second. Kidneys release a substance called renin, and then we get angiotensin. Now what the angiotensin does is angiotensin 1 recirculates throughout the body, and then ACE here in the capillary alveolar membranes of the lungs convert angiotensin 1 to angiotensin 2. Now if angiotensin 2 is liberated, then what that does, adrenal cortex, secretion of aldosterone, sodium retention occurs, antidiuretic hormone from the posterior pituitary, cardiac and vascular hypertrophy, systemic vasoconstriction, increased thirst, and an increase in blood volume. Now, what angiotensin II does for us, very simply, is increase our blood pressure. So if we can stop the conversion of angiotensin I to angiotensin II, we will get a decrease in all of this. Now, that was a long dissertation there to tell you that we're fixing to talk about an ACE inhibitor. If I block ACE from working, then angiotensin I never gets taken to angiotensin II. Captopril. General knowledge. Generic on this is captopril, and the trade name is Capoten. Mechanism of action. ACE inhibitor that is not a prodrug competes with angiotensin I for binding to ACE and inhibits the enzymatic proteolysis of angiotensin I to angiotensin II, thereby reducing long-term blood pressure. So we will see a lot of patients on ACE inhibitors, and medicine is given to them to decrease their actual blood pressure or to be kidney protective if they are diabetic. Diazoxide, general knowledge. Hyperstat. Diazoxide relaxes vascular smooth muscles in the peripheral arterioles. It causes vasodilation and decreases peripheral vascular resistance. Diazoxide lowers both systolic and diastolic blood pressure and inhibits also pancreatic insulin release. And without insulin, this would result in an increase of blood glucose. So we get vasodilation. But however, if we ever use diazoxide or hyperstat or proglycine, we also get a increase in blood glucose. Lisinopril, general knowledge, this is another ACE inhibitor. Lisinopril, an angiotensin converting enzyme inhibitor, is used to treat hypertension, congestive heart failure, post-myocardial infarction. There's generally a specific cocktail that they'll give patients at the point that they've had a heart attack. They'll generally give them a beta blocker to reduce myocardial oxygen consumption by reducing contractile force strength, and they'll generally give them a lisinopril. The lisinopril decreases their overall peripheral vascular resistance. So what that does is that allows the heart to not work as hard. Nifedipine, general knowledge drug as well. Mechanism of action, it's a calcium channel blocking agent. Selectively blocks calcium influx across the cell membranes of cardiac muscle and vascular smooth muscle without changing serum calcium concentrations. This is utilized as both an antianginal or anti-chest pain and an antihypertensive drug. General knowledge, though, we don't use this so much in EMS anymore as a primary drug. Nitroglycerin. Very simply, nitroglycerin, this is this vasodilation thing that I showed you earlier, allows nitric oxide to be formed in the blood, and that causes direct vasodilation to occur. Vasodilation, if you have an atherosclerotic plaque, is kind of a good thing. The dilation of the vessels around the heart or the coronary arteries would give more blood supply in an acute event. Nitroglycerin, organic nitrate, a potent vasodilator with antianginal, anti-ischemic, and antihypertensive effects, relaxes vascular smooth muscle by an unknown mechanism, resulting in a dose-related dilation of both venous and arterial blood vessels. It also promotes peripheral pooling of blood, reduction of peripheral vascular resistance, and a decrease in venous return. Very simply, nitroglycerin comes in many forms. We can give it sublingual, we can actually put paste on someone, we can even start a continuous infusion. We have to watch the patient's blood pressure. So at a minimum, every 5 minutes, reassess your patient for blood pressure, because this medication, the more it's put on, the more compounding it would actually get. Adult sublingual dose is 0.3 to 0.4 milligram tablets. Repeat every 5 minutes as needed to a total dose of 0.9 to 1.2, 3 doses as necessary. Adult IV bolus, 12.5 to 25 micrograms, followed by an IV infusion. The infusion, we start off at 10 mics per minute and increase by 10 mics per minute every 3 to 5 minutes until a desired effect. And this would be pain-free, chest pain-free, or close to chest pain-free, where we have them on a continuous infusion of nitrates. Maximum dose is 200 mics per minute. And this is a little bit on preparing the infusion. 50 milligrams of nitroglycerin to 250 ml D5W, or normal saline glass bottle. The lingual spray, 1 to 2 sprays at 0.4 milligrams, sprayed directly under the tongue. Additional 1 to 2 sprays every 3 to 5 minutes for a total of 3 sprays. You double dose them though, you may get more results than you want. The ointment is 1 to 2 inches for every 8 hours, up to 5 inches every 4 hours. Adult transdermal patch, 2.5 to 15 milligrams. So we have this in a multitude of forms, and you will see your patients definitely on this. Some of your EMS services as you go to work for might actually have ointment or paste. Pediatric dose is not recommended for out-of-hospital use. Contraindications: do not administer nitroglycerin to patients with a hypersensitivity to drug, head trauma, hypotension, or hypovolemia. Do not administer to patients in shock. Do not use in patients with severe bradycardia, less than 50 beats per minute, or tachycardia, greater than 100 beats per minute. Nitroglycerin should not be administered to patients taking medication for erectile dysfunction. Things like Cialis and Viagra essentially do the same thing. They vasodilate for erectile dysfunction. So this medicine here is really going to potentiate that. You will make somebody severely hypotensive. Nitroprusside. Nitroprusside, very simply, is a direct-acting smooth muscle dilator. Generic on nitroprusside is Nitroprusside, and the trade name is Nitropruss. Nitroprusside has direct vasodilative effects on both peripheral venous and arterial smooth muscles. It's a vasodilator. We use it as a vasodilator or antihypertensive. Please take a look over this. You will probably see some of these in clinicals. Adult dose, 0.1 mics per kilogram per minute. If necessary, titrate upward every 3 to 5 minutes to desired effect. Usually 5 mics per kilogram per minute. Do not administer nitroprusside to patients with hypersensitivity to the drug. Decrease cerebral perfusion. According to some local protocols, however, there is no contraindication to nitroprusside in a life-threatening hypertensive crisis. Onset's less than 2 minutes and duration is 1 to 10, and it is excreted in the urine. Verapamil, generic, and trade name is Altace. You might see patients on this as well. General knowledge. Blocks the conversion of angiotensin 1 to angiotensin 2. So this also is what we talked about earlier, an ACE inhibitor. We give it for hypertensive, 2.5 milligrams once daily. For CHF, congestive heart failure, 1.25 to 2.5 milligrams. And prevention of MI or stroke, 2.5 milligrams once daily. Pediatric dose is not recommended. Pharmacokinetics, onset 1 hour, half-life is about 13 to 17 hours, and it's excreted in the urine. This ends part 1. References on this were taken from Beck's Pharmacology for EMS Providers and Delmar Learning, and Bledsoe's Pre-Hospital Emergency Pharmacology, 7th edition. References from websites were taken in the following areas for the actual graphics. And if you have any questions concerning this chapter, please feel free to give me a call. My name is Roy Smith, smith@emsa.net, or 45219-7613. Thank you.